Here we go.
Okay, so I'm going to go ahead and share my screen here. Okay, so thank you for the invitation to come and speak with you all tonight. Tonight, I'm going to be talking with you about one of the bills that's called HF 385. It's a bill for responsible hospital discharge of psychiatric patients. And just to kind of introduce who I am and why I'm working on this bill, I am not a mental health professional, and I always like to make that clear. Mostly for this bill, it's because I am a mom. Um, but I work very much in the space of advocating for improving the treatment of people with severe mental illnesses like schizophrenia. And in fact, I ended up retiring from my career as a PT to do this work. And I've been a lobbyist now at the Iowa Legislature since 2020. Although I'm unlike the other lobbyists in that I don't get paid by anybody. And I do a lot of different types of work in the state on a volunteer basis. And I also now, for about the past year, am the legislative advocacy manager for the Treatment Advocacy Center. For them, I'm tracking legislation across all 50 states and in the federal government, and then educating and mobilizing advocates in each of those respective states to try to pass bills that are helpful for improving the treatment of people with SMI. And the reason why is that my husband and I have two adult children, and I'm very happy to tell you that our daughter is healthy and well, but our son is not. He lives with a very severe schizoaffective disorder. And I always like to show pictures of him early on because he was just like every other kid. He was healthy, happy, funny, creative, artistic, smart. And then, of course, in his teenage years, that changed with the onset of his severe mental illness. Um, and the reason I've moved into advocacy is that over the past 19 years, our son has gone through the revolving doors of all of these hospitalizations, drug rehab because he has a co-occurring substance use disorder, tried to live in residential care facilities, group homes, and our home with community services. And it wasn't until he was sick already for about 14 years that he finally got an extended stay at the state hospital in Independence, where he received finally the level of care that he really needed far sooner. And I always like to make the point that the MHIs in the state of Iowa are not a lateral transfer. It is a completely different level of care than what you can get in a regular acute care hospital, no matter what the language is around that from people in official positions. He presently is in an IRSH, a new level of care called an intensive residential service home for people with severe mental illness and complex needs. Um, and I'd like to share the picture of the brains below because what I hope for every audience to take away is because of the fact that currently we are unable to have somebody go into the hospital when they're having that first psychosis and stay there or some other level of support with enough support where they actually keep them long enough to figure out the right medications and let the brain heal up enough so that the person can become cognitively aware of their own illness. Because we don't do that and we can't do that, we are actually actively causing people's brains to become so much sicker than they have to be. And if I were to think about all the different ways in which I'm advocating, my primary goal is to stop letting this be a reality for the next kid that gets sick with a severe mental illness. And currently in Iowa, and for any of you that are presently working in an acute care hospitalization, I want you to know that these are not criticisms of specific providers, specific people in the system. It is a criticism of the overall system, and I hope you will take it at that. But we have a problem with some patients being discharged from psychiatric units with way too little support in the community where everybody feels that everybody needs to be. Some are sent home to families who are not given any information about what's going on, what the diagnosis is, what the meds are, when the next appointments are. And then, you know, it's not too terribly surprising when somebody doesn't show up for their next appointment. Some people are actively being discharged to homeless shelters without any plan for follow-up and without support, and sometimes without even notification to those homeless shelters. Um, some people are literally being streeted with no communication to their guardians, their outpatient providers, their group home care teams, or their families. And when I say the term streeted, what I mean is they are walked out the door and they're left there standing on the street. And for anybody that doesn't think this is happening in Iowa, I'm here to tell you it is. I hear from families and providers and lawyers on a very regular basis where this is happening. And unfortunately, it becomes a very common pathway to homelessness, incarceration, and death in many cases. And homelessness in and of itself is a risk because we know that people have a much higher mortality rate once they become homeless. It's known to be 4 to 9 times higher than that for the general population. Often that's where people are really victimized, especially female people with an SMI. And untreated symptoms cause people to end up getting arrested and incarcerated. And we think that the SMI people are about 1/3 of the homeless population. Most of us that really do this work really believe that number is much higher because people that are trained to go out and count homeless people are not trained to recognize somebody with an untreated severe mental illness, right? And people with untreated severe mental illnesses often have no idea that they're sick, so they're not going to raise their hand and say, "Yes, I have schizophrenia." So we actually think it's much higher than that. And they're just one part of what we call the SMI churn, the going through the revolving doors, and it really puts people at risk. A couple of specific examples that I have of people where this has happened. We know parents who were guardians for their daughter they were simply just not notified when she was discharged from a hospitalization. Who they were notified by was local law enforcement when they came by to notify them about her death from suicide. That could have been prevented had the guardians been notified. Another more recent example was a mobile crisis team took a patient who had been in and out, in and out, in and out of the ED and hospitals and mobile crisis. And they really felt that the person had finally met the criteria for inpatient hospitalization. And they took the person to the hospital and requested that they be notified when the person was released, whether that would be from the ED, the crisis stabilization unit, or the psychiatric unit. They were never notified until the person died by suicide. That's how they found out that the person was no longer in the hospital. It's happening to both families and professionals. So HF 385 is a bill to prevent all of that from happening. And what it says is that if a psychiatric patient is receiving inpatient care under a court order, prior to the discharge from the hospital, the facility or the hospital shall do all of the following. Refer to an ASO. That's the Administrative Service Organization, which is going to be responsible for all of outpatient behavioral health over the state. By the time this bill goes into effect, the ASOs will be in effect. And so the referral is for evaluation, case management, and post-discharge services. It's a way to ensure a warm handoff and higher level case management than what currently is happening. Also an assessment for suicide risk above and beyond just documenting, hey, the patient says he's not suicidal or homicidal, right? All of these psychiatric patients know how to say, no, I'm not suicidal or homicidal, even while they might think that a gang of drug dealers is coming to kill them at the same time, right? It will also require that they provide a 7-day supply of each medication. Initially, it was going to be a 30-day supply. We got pushback from Unity Point, who registered against the bill. And the compromise has been met, apparently, to now have that changed to a 7-day supply of each of the medications that the person's taking while they're in the hospital. And they're going to be required to provide the person or their legal representative with a discharge report. And that report's going to include the person's name, address, dates, times, and locations of all their appointments, the list of their medications, contact information for the ASO to which the person's been referred, written patient-centered aftercare plan, including crisis prevention and steps to address ongoing needs, educational materials for the person and the individuals who are willing to support the respondent, just like we would do if we were discharging a child with cancer or a mom with Alzheimer's. We would include the family and loved ones in that education. Descriptions of the symptoms of substance use disorders so that we can recognize that if needed, warning signs of decompensation, and information of educational services in the community and statewide. That's a critical piece because a lot of families end up getting a lot of support through NAMI, the National Alliance on Mental Illness. And unfortunately, a lot of families never hear of NAMI until they're already in the system and working for about 7 to 8 years trying to help somebody because nobody bothers to refer them. They're also going to be required to notify the ASO that the person's getting referred to and the person's guardian, parent, spouse, attorney, adult siblings, whoever is supposed to be applicable and in support of the person. The ASOs, in turn, are going to be required to coordinate the post-discharge care, including and not limited to contacting the patient to ensure that they attend the scheduled appointments and receive the necessary care and services, and to follow up with a patient in a timely manner, whether that be via visiting the person at their home, calling them, or some other means of contacting them. And in addition to that, they're also going to have to do a quarterly report. And this is probably one of my favorite pieces because it's going to provide some level of oversight and accountability. The ASO is going to have to report on a regular basis about the number of people being discharged and referred to the ASO, the outcome of each person that was discharged, any issues encountered while ensuring each person's continuity of care, and they will make the reports confidential and comply with HIPAA. But this is an important piece because it's a way of tracking. If we're not measuring how many people are disappearing out of the system and not getting follow-up care, we don't know how big the problem is. So currently the bill has passed through the House Health and Human Services Committee, and next it will be going on to the House floor. And assuming that it passes there, which I think it will, it'll then move on to the Senate, and then it will likely get assigned to the Senate HHS committee. I have briefed chair of that committee, Senator Mike Klimisch. He's aware of it, but that's a person to definitely be advocating with. So how to help with it? First, in the initial period, it would be encouraging all House representatives to pass the bill on the floor. Then it could be emailing Senator Mike Klimisch to encourage that the bill does get assigned to subcommittee and a subcommittee meeting and supported. Then you could be emailing or talking with Senate HHS committee members. And then ideally, if it gets through there, then encouraging all senators to also support the bill. So these are kind of some of the targets for who you might think about interacting with if you agree with this bill. Some talking points. Well, if we are responsibly discharge planning patients to the appropriate people for follow-up care and ensuring that everybody's getting the communication that they need, it is less likely that they're going to drop out of care and end up coming back over and over again into the hospital, putting a lot of stress on the demands for the very few beds that we still have in the state. Healthier patients are a lot less expensive. And it's both a patient protection and a public safety bill. Because sadly, people who are untreated for severe mental illnesses are also sometimes, depending upon what their voices are saying to them when they're untreated, sometimes they do commit some acts of violence. And I hate to say it, but it is a safety bill on multiple levels. And really what this bill is about is something that I've been advocating for quite some time. We know the system is very broken. And in my experience over the past 19 years of having our son discharged back to our home over and over again when we were obviously not able by ourselves to keep him engaged in treatment, I would see providers throw up their hands and say, oh, our hands are tied. There's just no other place to send him. The laws won't let us do this. The laws won't let us do that. And what I encourage people to do is that know that there's a lot of us out there working to improve the number of beds, the number of facilities, the number of providers, the amount of reimbursement. We're trying to do all the things to fix all the broken parts of the system. But what we try to encourage people to do is think about fixing it one person at a time. I've seen this work where I live here in Johnson County, Iowa, where if we have somebody that is circling that drain and going downhill, and we get people to come together in a community to collaboratively work together with the appropriate services, with the appropriate housing, the right level of support, we can save these people one person at a time. This bill helps us to do that. And then one of the questions that came to me earlier is, how did this bill come about? Well, it came about in a couple different ways. One is when we started working on advocacy as citizen advocates to improve Iowa's commitment law in 2018, we started building relationships with legislators. That led to me getting a meeting early on when our HHS director, Kelly Garcia, was hired on to do some advocacy with her. That eventually led to her asking me to give a big advocacy talk when they had all the legislators up at the MHI in Independence, touring there, and start having a day talking all about how to improve the mental health care system. She had me give a talk where I basically shared a little bit of our son's story, the history of the mental health crisis in the country, multiple state solutions that we could be thinking about doing, and a little bit about AOT. And from that came several bills over the past 2 to 3 years, right? The loan forgiveness, the increased reimbursement rates, trying to add more beds at the state hospitals. So every year since I've become a lobbyist, I set up pre-session meetings with the legislators, just like every other lobbyist probably does. And I end up pitching some more bills. And some of that more recently has come from my work for the Treatment Advocacy Center, wearing my other hat, where I am literally reading bills from 50 states. And what I became aware of very quickly was that there are similar bills that have passed, like in Michigan and Louisiana, for instance, where they have started putting in responsibility bills for the hospitals as they are discharging, very much to combat the problem of the streeting of so many patients in our country. So it came from building relationships over time, getting those pre-session meetings. And I actually pitched this kind of a bill 2 years ago, and it wasn't taken up by Representative Meyer that year. But this year, during that pre-session meeting, she came to me and asked me for bill language and samples from other states. So that's how this bill came about. And that came about in part because she had some constituents who had loved ones where this happened. Their loved ones were streeted and they lost them. And so, it came from grassroots people. So I'm going to stop talking at you and open it up to questions. And for just a moment, I'll also just share my email and contact information. And I'll stop my share and open it up to questions. Hi, Maggie.
Hey, Leslie, thanks for sharing your story and all this good information. I do have a question about some of the opposition we might face in our personal or professional advocacy for this bill. What do you anticipate folks not being in agreement with, or what are some of those? Yeah.
Yeah, I can tell you specifically what Unity Point said during the subcommittee meeting in the House. They said, we don't need this bill because we're already doing it all, and it's an unfunded mandate. So which is it? You're already doing it or it's unfunded, right? They felt that it was going to be too costly to have to provide that 30-day supply of medication. And that's where the compromise came to 7 days. And they also said that it would put more strain on hospital beds and that they might see that hospitals would want to shut down their psychiatric units. And my counterpoints to all those things was, if you don't have the psychiatric meds, you're going to just deteriorate again. You're going to end up back in the hospital. So it's going to continue to put stress on those few hospital beds that are there. And it's putting people at risk of being sicker and sicker. And people who are sicker end up costing more than if we did the right thing in the first place and got them that warm handoff and got them set up with the appropriate services and level of care that they need. It actually lowers the stress to every part of the system. Other questions, you guys?
Unfortunately, I wasn't able to go to that subcommittee meeting, Leslie. But I think some of the things that I have heard is that there's just nowhere to refer people. And so it's, but you've got it laid out where you want them to um, refer people to the ASOs. And I don't even remember what that acronym is. It's so new. Remind
Yeah,
me.
the Administrative Service
Right.
Organization.
Thank you.
Mhm.
Um, so, what would be your counterpoint to that?
My counterpoint to that is, if for each person, especially early on, and they're having their very first psychosis, if we approach them as carefully as we would a new young person with cancer, and in the case of having a psychosis, if we referred them to a first episode psychosis education program that literally wraps them and their loved ones in services and support for the first 2 years, those people would not end up in the revolving door. It's been well shown and well documented, the research around it, how much they keep them from coming through the doors repeatedly. So if we thought about this one by one, like I said, especially at the beginning of these illnesses, we could literally reverse all of the problems that we're having with people getting so sick and going repeatedly back in and out of the hospitals and every other level of care. And I guess my counterpoint is, just because there isn't enough beds or enough facilities for people to go, does that make it okay to put them on the street alone with no help? And do we think that that's solving the problem? Because the answer is no, it's not solving the problem. And it's also leading to what they have availability of much more than their psychiatric medications and support are adverse substances that are out there, street drugs, things like marijuana, things like meth, right? That are only making them more sick and more aggressive. And that's raising assault rates in the emergency departments and in the psychiatric units. And so if we step back from it and look at it from a bigger lens of, does this make sense to have somebody in the hospital, number one, for too short a period of time, and then send them out to nowhere and nothing? And we expect that that's going to change. Doing that over and over again is very much what we call the definition of insanity, right? Doing the same thing and expecting a different result. So what I'm proposing, and what this bill is proposing, is to get it set up so that you're having the handoff to intensive case managers whose their job is to provide a level of coordinated care that is supposed to work better with this new system, right? That's the big sell of it. Have it be that they're engaging to try to make sure that the level of care is being found that the person really needs. We can't wait for every single piece to be in place and just keep streeting.
Sounds like, Leslie, at least the demand, like at least there's a better way to assess the demand for the need for services with this bill and having the reporting mechanism to that. So even if we're
Yes,
not able to solve the problem, at least we'll be able to understand the scope of the problem.
that's exactly right. Yeah, that is one of the wonderful things I like about it. Much like ORS, the Office of Recovery Services, tracking all the calls that are coming in from people looking for services. If we're not tracking it, we don't know what we have. And so I love the fact that they've built that in.
Have you heard anything from the ASO? I'm calling it the ASO because they're going to all be run by the same
Right.
organization, but there are
Yeah.
multiple sites. I don't even know how many ASO districts are there.
I think it's 8
8.
7. Okay, 7. Thank you, Maggie. And have I heard anything specifically from them? No. Is it on my list of things to talk with them about when I get my meeting with them? Yes. Yeah.
Caitlin, I don't want to put you on the spot, and I also don't want you to feel like you have to speak for your employer. But since you're here and a bit of an expert, and I, want to make sure that we can do well on this. Did you have any feedback on the bill? Like, did it sound like it was doable from your end? Are there things that you think that won't work, or things that you think that sound good?
I think it would work. Um, I mean, it all comes down to people just needing to help to do their job, I guess. From my standpoint, is like if they have a guardian or family involved, like they're informed. So hearing that side is just crazy to me. But anything to help the patients, there's definitely a lack of services. So that makes me a little more nervous. Just because I know there's wait lists to get services in place. So oftentimes, when we have to send them out, they have an appointment that they have to wait a couple weeks for, and then they're on the wait list for services, just since there are so many. But it sounds good as long as it works and runs smoothly and everyone's on board.
So here's a question. Thanks, Caitlin, for reminding me of this one. What if the person doesn't have a guardian?
Then it would be whomever is associated with them and helping them, or maybe if they're coming from the group home, informing them. If they're coming from a shelter, at least informing the people at the shelter, whoever they have around them. But to Caitlin's point, sometimes they no longer have people around them because they've gotten lost to us. And a lot of times people in the general world think that the families are abandoning their loved ones. And what's not often recognized is that it's our loved ones in psychosis having a lot of paranoia who lose us, right? They run away and they end up in some other city. I know families that are looking for somebody in St. Louis or in some city in California because their loved one has literally walked across the country. And in that case, then all efforts should be made to try to reach out to the family if they can find that information out. But you're right, if they don't have anybody, even more so, that's why we need an intensive case manager with the ASO to step in and be that support system to get the person to the right level of care.
So Grace, you're a student, and this is kind of our target audience because we're having our lobby day a week from tomorrow. Anything that you found that you thought might be any questions that you have, I guess just put it that simply.
Yeah, I guess I was curious about other states that have done this, like you said, Michigan and Louisiana, and the research, and just if you could kind of speak to the history of these programs and kind of the results that they tend to
Yeah.
get.
I'm happy to tell you, in Michigan, it was actually started by somebody who is a judge. Judge Milton Mack has been one of the big proponents of doing assisted outpatient treatment, which is when somebody's under a court order to get outpatient treatment because they don't know they're sick in the first place. And they've been doing that via Kevin's Law for quite some time in Michigan. And he had the experience, and their team had the experience a few times of a hospital um, discharging people who were under court order as outpatients, but they had gotten worse. They went into the hospital and then they were discharged with no communication to the court, no communication to the care team or any of the family or anybody. And so he had the law changed to require that they have to do that notification and coordination prior to discharge. And in their law, they actually can charge the hospital with contempt if they fail to do that. So not only do they have the law, but they have teeth. They have an ability to follow through with fining the hospital for not doing that. So it was actually a judge-initiated program. Same thing in Louisiana. It was very much from the experience of some of the people running AOT programs where they had somebody go back into the hospital and then they were discharged and just released to the street, and they completely lost some of the people. Lost both in terms of physically lost, couldn't find them, but also lost to suicide. So it came from professionals getting involved in the space of trying to keep people in treatment on the outpatient side of things. And the hospitals were not doing their part of doing that appropriate community collaboration that should have been happening.
I see. Thank you.
You're welcome.
I do have one more question, more about not like this bill specifically, but your work as an advocate and a lobbyist. And I guess essentially, like, how do you keep track of everything if you're, you're monitoring things in all 50 states? And I like, what's your system?
Yeah,
that's
it's a
like
good question. When they first offered me the job, let me tell you, that was my top question. How am I going to do that? I can't get onto 50 state legislatures plus the federal government's website and learn them all. We use a bill tracking system. This one happens to be called Bill Track 50. And you put in certain keywords and different types of structures of sentences and words that track the kind of legislation that you're looking for. And every day I get an email from them of bills that have either newly been filed or they're getting scheduled for their their hearings and subcommittee meetings, that kind of thing, as they move through the thing. It sends us alerts to different things as those bills are progressing. And then from that, I go through and assign like kind of a priority list and track the priority bills that we know are going to make a difference for people with SMI. And then we use another program called Voter Voice to send out advocacy alerts to our email lists that we have in all 50 states and mobilize people. So that's how we keep track of it. We also do a lot of educational programs to help educate people that want to get involved in the work of SMI advocacy, which thankfully it's a growing number of people.
Leslie, do you have any legislators in particular that you'd like us to target? Like maybe the ones that might be on the persuadable side, not quite there, or maybe ones that just don't know that much about mental health. I suppose that's all the new folks, because there's quite a few new folks in the House.
There are quite a few other new folks in the House, and I would just say whatever ones you already have as your own legislators would be a really good target. And sometimes, believe it or not, I don't want to answer that part of the question. I'll avoid saying that because I know I'm being recorded. I would say any legislator who has no experience in terms of the mental health space. So people that are there primarily in the business world who don't have any idea that this is happening. I think that would be probably a reasonable person to try to persuade. Because I'll tell you, some of the comments I got back as I started having meetings early in the session was, doesn't this already happen? And the answer is no, it doesn't already happen. It really doesn't, and it should.
Caitlin, any last questions or comments from you?
Just a clarifying question. This is for anyone who has a psychiatric hospitalization, or do they have to meet like a certain diagnosis?
It's for anybody who is there under a court order. So they've been
Court order.
involuntarily committed.
Okay. Thank you for clarifying. Because that makes a difference. Because we see people who don't want any family or friends involvement, but they're not under court order. So that makes sense.
Correct. And I would just say to that, I hope you keep in mind that if somebody is acutely in psychosis, they often have paranoia, mostly about their family and loved ones. And if they have schizophrenia, schizoaffective, or bipolar disorders, those are neurodevelopmental disorders that are mostly not caused by something done to them by a family member. They're genetic, biological illnesses. And I would encourage you, after they've been there for a little while, to think about re-asking them whether they could be contacting their family members to sign a release of information form. Because often as a person comes back out of psychosis, they really do want their family members involved. And I'm sure you know that, Caitlin, but I just wanted to say that because I
No, I
have lived
definitely get
this on both sides.
Yeah. Well, thank you so much for this. It was really informative.
Thank you. And thank you for the work that you're doing.
Thank you.
Thanks for joining us, Caitlin.
Yeah, thank you so much for this.
Oh yeah, happy to do it. And if anybody asks you about it, I'll get it up on YouTube in the next, hopefully 24 hours so that other people can watch if they're interested.
That sounds perfect.
Okay. Grace, any last questions?
No,
Thoughts?
no, but thank you. Yeah, this was a great distillation of the bill, and yeah, thanks.
Leslie, any last words for us?
I just want to say thank you for letting me tell you all about the bill, and thank you for any support you might decide to lend to it. We appreciate it.
Okay, I'm going to turn the recording off now.